So today we have a young patient who has a complete ACL tear in his left knee joint. As you can see on the diagnostic arthroscopy, you can clearly see there is complete ACL tear from its femoral attachment. And we are going to do arthroscopic ACL reconstruction for this patient. So first we are going to debride the remnants of the torn ACL, and we are going to mark our ACL femoral and tibial footprints. And now we go in the medial compartment of the knee joint, and you can see that the medial meniscus is normal. There is no injury. As per MRI, there was no injury in the medial meniscus, but still we do diagnostic arthroscopy to see under vision whether there is any small tear which is missed in the MRI. And now we are in the lateral compartment, and the MRI has reported that the lateral meniscus is normal, but on diagnostic arthroscopy there is longitudinal tear involving the posterior horn of the lateral meniscus. So here I want to emphasize that we should always do proper diagnostic arthroscopy in all of our cases. This practice makes sure that we never miss any injuries which were missed in the MRI. So we are going to repair this lateral meniscus posterior horn tear with all inside device. So first stitch has been taken in the superior portion of the torn lateral meniscus, and the second stitch is going to be taken in the inferior portion of the torn lateral meniscus. And now we are going to withdraw the all inside device, and then we are going to pull the suture to tighten the knot. So this completes the lateral meniscus posterior horn repair. So after tightening the knot, we are going to cut the thread flush to the knot. So now lateral meniscus is quite stable, and this is going to prevent further progression of the posterior horn lateral meniscus tear. So now we shift our focus towards ACL reconstruction, for which I have introduced my femoral ACL hammer from the anteromedial portal. This is a 7 mm offset femoral hammer through which I am going to drill the guide wire in the lateral femoral condyle. The guide wire is drilled in the ACL femoral footprint, on top of which we are going to drill with the endo button drill bit in the lateral femoral condyle. Because of the markings on top of the endo button drill bit, we can know the provisional length of our tunnel, which is around 40 mm in this case. 40 mm is a good length as far as anatomical ACL reconstruction femoral tunnel is concerned. So now we are going to use a depth gauge to measure the actual length of our femoral tunnel. So you can see that the length of our tunnel is 40 mm. Now we are going to pass the guide wire again in the femoral tunnel, and we are going to drill with 10 mm drill bit, because that is the diameter of our ACL graft. In this case, we have prepared the ACL graft from peroneus longus. We have tripled the peroneus longus, and the length of our graft is 10 cm and the diameter is 10 cm. So now you can see that we have drilled up to mark of 30 mm in the femoral tunnel. We are going to keep 20 mm graft inside the femoral tunnel, and rest of the distance is for the flipping of the endo button. Now we are going to see our femoral tunnel from the anteromedial portal. You can see that the tunnel is in its anatomical location. There is no blowout. So there is a good ACL femoral tunnel. Now we are going to drill the guide wire through the tibia with the help of tibial ACL jig. And you can see that we have kept the jig in such a way that the guide wire exits just posterior and medial to the anterior horn of the lateral meniscus. On top of the guide wire, we are going to drill with the 10 mm tibial drill bit. And once we do that, we are going to pass our graft from the tibial tunnel to the femoral tunnel attached to the 20 mm continuous loop endo button. And we are going to flip the button on the lateral femoral cortex, and we are going to fix the graft with the help of interference screw at the tibial end. And this is the final picture of our ACL graft. You can see that it's quite strong and robust graft for this particular patient, and it's going to provide good stability in this patient. It is anatomical in its location, and you can see it's quite strong. And now as we see the graph from the anteromedial portal, this is how it looks from the anteromedial portal. It's quite good and strong. Anything less than 10 would be suboptimal for this patient. That's what I feel. And now we finally extend the knee to make sure that there is no graft impingement, which is important to check when we have such huge graft. Thank you.